Okay ma'am.
Okay.
Okay
இவங்க
ma'am. We are live now,
ரத்லமோட
ma'am.
பிரசிடென்ட் செக்ரட்டரி இருக்காங்க. Okay ma'am. நல்லா இருக்கீங்களா மேம்?
நல்லா இருக்கேன். டிராவல் பண்ணிட்டே நல்லா இருக்கிறேன்.
டிராவல் பண்ணிட்டே இருக்கீங்க. மெலிஞ்சிட்டீங்க டிராவல்லயே.
Okay. We are live now, ma'am.
Okay.
Yes. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with other societies. So let us start the webinar with Saraswati Vandana. It's my privilege to introduce the MOC of today's webinar, Dr. Radhika Gauri ma'am. Ma'am is the specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you for the kind words, Sahiti. Good evening to all respected faculties and delegates. It is a very important topic today, and we have Dr. Sampath ma'am, who is standing for elections for the president of FOGC, and we welcome her. And I thank Dr. Amala ma'am for the opportunity. I would like to introduce Professor Sampath ma'am, who is our FOGC Vice President, who's been from 2022. She's very active.
Okay, Radhika. Okay.
Yes, ma'am.
Thank you, Dr. Radhika, for the nice words. Always, our Radhika is our MOC for all our TNFOG program. And I welcome you all for this TNFOG with Ratlam, Meeraj, and Kolhapur societies, the webinar. The topic is on emotive bundle and panel on hypertensive disorder in pregnancy. I welcome our TNFOG President, Dr. Amala Madam, and our past TNFOG President, Dr. Ramani Devi as a chief guest, and the felicitations of Ratlam Society President, Dr. Sunita, Secretary, Dr. Aditi, and Meeraj Society President, Dr. Shravani Jadhav, and Kolhapur Society President, Dr. MJ Nagavatkar, and Secretary, Dr. Ranjita. We have the wonderful talk by Dr. Shanti Rani, Professor, retired professor from Theni Medical College, and topic on emotive bundle and chat by Dr. Chandrakala Maran, who is the professor from Coimbatore. And we have the panel on hypertensive disorder in pregnancy moderated by our Ratlam Secretary, Dr. Aditi Rathore, and the expert being Dr. Sumati Surendran. And we have the wonderful panelists, Dr. Sonia, Dr. Nasia, and Dr. Siraj Fatima, Dr. Teresa, and Dr. Shailesh, and Neha, and Dr. Roma, and Shaileshia. So I welcome you all for this CME. And now I have the pleasure to introduce our TNFOG President, Dr. Amala Devi Madam. Dr. Amala Devi Madam is the President of TNFOG, and she is the President, first President of Dindukal Society, and she was the IMA member and EC member, and President of Dindukal Munnetra Tamil Kalagam, and many awards. Every year, Madam will be getting the best awards from government and from the society, IMA, Lions Club, and everything. Amla Madam, few words.
Good evening and best wishes to all who are participating in this webinar on behalf of TNFOG. I should thank Dr. Sampath Kumari for organizer of this webinar for giving me an opportunity to participate in this webinar. So welcome to Dr. Ramani Devi, past president TNFOG, and my friend. All the president and secretaries of today's webinar and from Ratlam OG Society, Miraj and Kolhapur. So now the first session will be an emotive bundle, which is a new innovation in the technique of managing PPH, and every person, every obstetrician or every the undergraduate should be thorough with this. They can manage PPH very easily. And then the next, the chairperson will for this emotive bundle will be Dr. Chandrakala Maran from Coimbatore, and the speaker will be Dr. Shanti Rani. And in session 2, panel discussion on HDP. This PPH and HDP are the two important causes for maternal death. So when you are well versed or when you are thorough with this, you can manage and reduce this MMR. And on panelists of this second panel discussion, and this every time from south, two people will be there to conduct all these webinars on behalf of our friend Dr. Sambat Kumari, who will be the next president of Foxy. We surely believe and pray God that she should become the president. And I request all the members and all the participants, all the panelists and everybody who is participating in this to vote for her. And I thank Dr. Madhumati and Radhika Gauri to conducting program. In always they will be the pillars of this all webinars, especially conducted by Dr. Sambat Kumari. So thank you all.
Thank you, Amla madam. Thank you. Because they are the two immediately they will accept.
Pillars,
So I will not
pillars
leave them.
of TNFOG in conducting webinars.
Webinars.
You should give
Yes, madam.
any awards if you conduct TNFOG conferences. They will be honored separately.
Sure,
Thank you,
madam.
ma'am.
Next time we will do it. Next time we will do it.
Thank you
Next,
for
I
the
welcome Dr. Ramani Devi madam. Dr.
Yes,
Ramani
ma'am.
Devi madam is our past president of TNFOG, past president of Trichy Society, and she was the endometriosis committee chairperson, and she was vice president of Foxy, and she has many awards. And the madam is the PhD scholar of endometriosis in microRNA of endometriosis, and she was the editor of Endometriosis Update published by Endometriosis Society of India. And now recently, Madam has started the endometriosis chapter in Tiruchi Society. Welcome, Madam.
Thank you, Sampath,
Ramani Madam.
for making me a part of this wonderful CME. First of all, I think I should congratulate you for involving almost all the societies all over India, and especially today we have the Ratlam Society, Meerut Society, and the Kolhapur Society. I don't know, I was long back, I was in Kolhapur Society when as a speaker on my way to Bijapur. So that was a very nice experience where I saw the Kolhapur Mahalakshmi also. So I wish, I think whatever the, regarding the topics and the speakers, Amla Madam has dealt in detail. So now it is my duty to request everybody to vote during the forthcoming election, and especially to Dr. Sampath Kumari. All of you know that Sampath Kumari is an able leader, and when she becomes the president of Foxy, I think it will be nice for everyone. And I request, in fact, all the members of the following above societies who are there with us today to vote and support her. And I wish this series of webinars will to be a successful one. And my special congratulations to Dr. Radhika and Madhumita for untiring work on conducting this webinars. I think Sampath has chosen a very nice person on this regard. And Sampath, for all the hard work you have been doing so much, so long, I think you should be the winner. And I wish to see you as the future president of Foxy. And thank you once again. Madam Amla, Madam, thank you to share my views here. And I think you can go ahead with the program, as I have to join the endometriosis webinar where I'm going to be the speaker next. Okay. Okay. Thank you. Thank you so much.
Thank you, Ramani Madam, for the nice, wonderful words. Okay, now I call upon Dr. Sunita, the President of Rathalam Society, the few words. Dr. Sunita? Sunita, are you there? Dr. Sunita, Dr. Shravani Jadhav, Dr. Ranjit, Dr. Naha Varkar, Dr. Aditi.
And Dr. Sunita is there now.
Yes, Dr. Sunita is there.
Good
Yes.
evening, ma'am. Good evening, ma'am.
Dr. Sunita, the President of Rathalam Society. Few words, Dr. Sunita. Welcome.
Good evening, ma'am. I wholeheartedly
Good
welcome
evening, Dr. Sunita.
very platform of this webinar, ma'am. And on behalf of Ratlam Obsgynae Society, I really wish you all the best for your upcoming elections. And we are so happy that you people, came along on the webinar. We would like to welcome you once you win the contest. We'd like you to visit Ratlam once, ma'am.
Sure, well, definitely I will come. If time permits, I will come, or otherwise I will come as President-elect to
And
your place.
once you are done with your election and you have your victory, we would like to welcome you at Ratlam like a president of Foxy.
Sure.
Ji ma'am. Ji ma'am.
Sure,
Thank you.
Dr. Sunita. Thank you so much. Thank you.
Thank you.
Dr. Shravani Jadhav, Meeraj President, are you there?
Yes, ma'am. Yes.
Yes. Yes, Shravani, few words.
Good evening, ma'am. I am really grateful for you to involve me in this webinar, and I wish you all the best. And I wish you will definitely become the president for the upcoming Foxy elections. And we also welcome you to Mirrors OBGY whenever you get time in next few years to give a lecture
Sure,
sometime.
sure.
And I love the stories that you put on the WhatsApp. They're very, very interesting. They have made me bring more interest in high risk cases. So I thank you for that also.
Thank you, Dr. Shravani. It will be continuing that knowledge series. Thank you, Dr. Meeraj, for the fine nice words. Dr. Ranjit and Nagavatkar from Kolhapur are there. I gave a talk.
Yes,
call
madam.
to
I'm Dr.
Dr.
Dr. Nagavkar, President Kolhapur Obstetrics Gynec Society.
Yes, sir. Few words.
Yes, madam.
Yes, sir.
You're
Few
doing a
words.
great job, madam, and very best of luck to you. And we would like to welcome you to Kolhapur and especially in Mahalakshmi Temple. Next time when you become a president of Foxy, do come to Kolhapur, madam. Yeah.
Sure, sir. Ramani madam was telling about that Mahalakshmi temple. Sure, we will come to that Kolhapur
Yes, madam.
Mahalakshmi
Yes, madam.
temple and
Yeah.
Cure Society. Thank you
Yeah.
so much for the
Thank you.
nice words,
Thank
sir.
you. Yeah.
Thank you, Dr. Sunita, Dr. Shravani Sejadav, and Dr. MJ Nagavatkar for the wonderful words. Now we'll go with the scientific session. Yes, sir.
Yes.
Radhika.
Yes,
You
ma'am.
can call Chandrakala Maran, madam.
Yes, ma'am. Now,
I request
moving.
all of you to vote for me, please. As Ramani madam and Amla madam told, I am contesting for Foxy president. The voting is August 1 to 10. All of you vote and make your members to vote.
Sure, ma'am.
Yes. Kangla.
Chandrakala, madam.
Otherwise, we will introduce Shanti Rani madam.
Speaker,
Dr.
yes,
Shanti Rani, put the CV of Dr. Shanti Rani. Dr. Shanti Rani madam was the HOD of Sahiti.
Yes, ma'am.
Yes, ma'am. I have shared the CV, ma'am.
Yes, ma'am.
Shanti Rani madam was
Can you see
HOD
it,
of Teni Medical College, and she was the president of Teni OG Society, founder treasurer of Teni OG Society, and she had all posts in Teni. And currently, she is the treasurer of our TNFOG and organizing chairperson for colposcopy workshop. And she has many awards to her credit: Best Women Doctor Award, Best Doctor IMA, Best Service Provider to PPIUCD, and Lab Sterilization. Welcome, Dr. Shanti. Stage is yours. So Dr. Shanti will be talking about the E-motive bundle.
Thank you, madam. Thank you, madam.
Slide share பண்றீங்களா? சாகிதி பண்றாளா?
நான் பண்றேன், madam. Try பண்றேன்.
சரி.
நம்ம இல்ல நம்மளும் இப்படிதான் எடுத்திருக்கோம். எந்தம்மா முடிஞ்சும் தெரியல.
Madam, is it visible? No, ma'am.
இல்ல ஷீல்டு தான் தெரியுது.
Vallaya.
ம்ஹும். நீ பிபிடி சாகித்க்கு அனுப்பிச்சுடு, அவ ஷேர் பண்றா.
Okay, ma'am.
எஸ்
I have shared from my
எஸ்
end.
சாந்தி.
No, you please wait. No, I cannot come out of this.
போடுவா சாந்தி.
Yes, madam. But it's
you
not
start.
coming to my screen.
உன் ஸ்கிரீனுக்கு வராது. இங்க தெரியலையா உன் ஸ்கிரீன்ல? சாகிதி, have you shared?
Shanti ma'am, can you see my PPT, ma'am? No, I can't see that. No, I cannot come out. Please wait, no. Please click on escape, ma'am, so that you'll come out of that escape button. Escape button, huh? Now, see, ma'am, can you see my screen, ma'am? Am I audible? Yes, ma'am, you are audible. I can see your screen. Shall I proceed? Yes, ma'am. Shall I
Yes,
proceed?
Shanti, you can proceed.
Okay. Yeah. My topic today, good evening to all. My topic today is emotive trial and a small introduction. Please, next slide, please. Postpartum hemorrhage. I want to have a small introduction about postpartum hemorrhage. Postpartum hemorrhage is defined as blood loss of at least 500 ml after birth, regardless of delivery. This is RCOG guidelines 2016, POXI 2015, and emotive trial. That it is a minimum of 500 ml is considered as postpartum hemorrhage, and 500 to 1000 is considered as a moderate postpartum hemorrhage. Clinically, any amount of blood loss that causes hemodynamic instability or signs and symptoms of hypovolemia in a woman is determined as a case of postpartum hemorrhage. The incidence is 2 to 4% after a vaginal delivery and 6% after a cesarean section. And it contributes about to 35% of all maternal death worldwide. So why this is so much of maternal death? Because the underlying thing is very simple: stop the bleeding and replace the loss. But it's causes, next slide please. Shahidi, next slide please. But the reason for high mortality from PPH is due to failure to recognize the excessive blood loss and estimate the amount of blood loss, and failure to provide timely treatment for the cause for PPH, and failure to provide early and adequate fluid replacement and treatment for shock. Next slide. And the postpartum hemorrhage is a time critical condition, and delay in the use of life-saving intervention can result in a loss of life. And also the transition of hemorrhage from the compensated to the decompensated stage is very rapid and easily overlooked. Hence, prediction, early recognition and intervention are crucial for lowering the risk of severe PPH and improving its clinical outcomes. Next. And the precision and prediction. This is an example that Ohino from Cape Verde, how he was enthusiastic in preventing the goals, and he played his role and he became a global enthusiasm on a single day. So that amount of prediction and precision and prediction is necessary when you are dealing with the antenatal period, and planning is highly recommended because early identification and management of patient will have better outcomes. So we divide the patient into risk and high risk. The medium risk is induction multiple gestation, and PPH, family history, chorioamnionitis, fetal demise, and polyhydramnios. And high risk is that suspected placenta accreta, placenta previa. So there is a category as low risk, high, medium risk. Next slide, please. Any patient with low risk can suddenly become will be always anticipating this complications in a panicked, and we are not prepared, and we'll end up in soup. Next slide, please. Next slide, please. Slide. Oh, this is the modified that is systolic BP, diastolic blood pressure, heart rate, and neurological response. 2 yellow alert or 1 red alert is indicating of the patient is endangering the impending complication. Next slide, please. Why there is a challenge? Because delayed and inconsistent use of interventions for the management of postpartum hemorrhage. Once or maybe delayed, or we are using inconsistent use. So the treatment of postpartum hemorrhage are often administered in a sequential manner. One first we'll try one and wait, and it's not working, then we are going for another, and it's not working, we are going for another. So it's getting a lot of time to change from one treatment to another treatment. So what is this emotive trial? Next slide. So the emotive trial is early detection of postpartum hemorrhage and treatment using a WHO first response bundle. Is a landmark cluster randomized trial. It's a bundle approach to reduce the severe postpartum hemorrhage. It was conducted in the African countries, and the primary outcome is the composite of severe PPH, that is blood loss of more than 1000 ml, or a laparotomy for bleeding, maternal death due to bleeding. This is the composite outcome of the patient. This trial showed when using a bundled approach, there is a 60% reduction in the severe PPH and laparotomy or death from bleeding. And PPH detection is improved from 51.1% to 93.1%. And adherence to the treatment bundle increased from 19.4 to 91.2. Next slide. So this is the way how the bundle approach is different from what we are using in a sequential manner. If you are aiming for with the one by one, it will take about 6 minutes. But when two people, the previous slide please, two people are aiming, then it will be 6 at a time. So this is an emotive bundle. It has a, this is two people, there is multiple people, multiple way, but at a single time. So the effect will be naturally, you can expect it's very good when you are using a bundle approach. Next slide. This is emotive. It has 6 components, and the first component is early detection and trigger the algorithm. How to detect? Next slide. Next slide, please. This is quantification of the blood loss postpartum. There are 2 methods. One is objective, another is subjective. The objective is gravimetry method or calibrated. Gravimetry method is using the dry weight of the dry gas, and after it is soaked, and 1 gram is equal to 1 ml. We are calculating the blood loss like that. The calibrated plastic sheet is the key component in the emotive. Artificial intelligence is incorporated, that a dry gauze and wet gauze can be differentiated from the blood from the non-blood material. And subject estimation, that is by visual estimation, it is not estimated correctly, and most of the time the blood drained is often not some amount of blood that is not estimated, which can assess exact whole blood loss. So when it is more than 300 ml, if it you need not wait for 500 ml, if it is even 300 ml, when there is pH, and you should trigger the other bundle of in the emotive. The next bundle is uterine massage. Next slide, please. That is massage. Normally, next slide, please. Normally, it's a component of amstel. That is given after delivery of the placenta. We are massaging the uterus, delivered, and PPH is diagnosed. We should immediately start massaging the fundus. So immediately postpartum, every 15 minutes for the first hour and every 30 minutes for the next hour. Even skilled birth attendant who are trained can do this uterine massage. So the uterine massage can stimulate the uterine contraction and maintain its tone. The next component is the most important component, oxytocin drugs. Next slide. The oxytocin drugs, next slide, please. It's a component of amstel. It's in a 100 ml.
Hello, Sahiti?
Yes, ma'am.
I think ma'am's internet is affected, huh?
Ma'am, rejoined, ma'am.
Ma'am, has it come back?
Yes, yes.
She's rejoined. Okay.
Am I audible?
Yes, ma'am. Just now you are audible.
Am I audible?
Yes, ma'am. Yes, ma'am,
Shanti
you're audible.
கேக்குது.
Yeah, the slides have stopped. Oxytocin drugs. It's up to oxytocin drugs. Oxytocin.
Sahiti, what happened?
Radhika, am I audible?
Yes, ma'am.
Yes,
You are audible
Shanti,
now.
you are audible.
But your slides have stopped, ma'am. Stopped moving.
Sahiti,
You?
Yes, ma'am, I'm resharing the slides, ma'am.
Next slide, please.
There is an internet disturbance, I think. Yes, ma'am. Now it's fine.
Okay. You can use other oxytocin drugs like methyl ergometrine. And also used. And
Shanti, ma'am, your voice is
Sorry,
breaking,
next
ma'am.
slide. Okay.
From 22,000 plus tax on. 22,000 plus tax on. 1 year.
1 year.
1 year.
Can I try again?
Yes, ma'am.
yes,
Trying
you
to-
talk. Continue.
I'm not audible.
You're audible, ma'am. Please
Okay.
continue.
Okay. Sorry that couldn't get the
Internet.
death due to bleeding from PPH 20%, and also there is reduce the incidence of laparotomy. And FIGO recommends administration of tranexamic acid as 1 gram of tranexamic acid intravenously over 10 minutes to be given, regardless of the cause of PPH. PPH, you can give tranexamic acid. Next slide, please. Next slide, please.
சாந்தி தெரியலையா? ராதிகா நீ
And now we
முடிச்சிட்டியா?
have come to the
Okay,
Again,
ma'am.
intravenous.
connected, ma'am.
இல்ல
எஸ் சாந்தி.
யாராவது ஒருத்தர் அந்த ஸ்லைட்ஸ் ஷோ பண்ணா இதர் ஷீல்ட் கம்பெனி அல்லது சாந்திராணி யாராவது
அவதான் பண்றா, சாகித்ரி தான் பண்றா.
தென் பை எப்போ ஏதாவது இந்த எரரா இருக்கும் நெட் கனெக்ஷன் அந்த மாதிரி
சாந்தி கண்டினியூ.
ஐதர் அந்த அவள்கிட்ட இருக்கத வச்சு டாக்காவது பண்ண சொல்லுங்க, ஸ்லைடு வராட்டி கூட பரவாயில்ல.
சாந்தி பேசுங்க.
ஆமா, யூ கண்டினியூ யுவர் டாக். Don't bother about the slides because everybody knows about this emotive slides, no? Shanti Rani.
I think ma'am has internet issues, ma'am. Shanti ma'am.
ராதிகா நீ IV fluid சேர்ந்து முடிச்சிடு.
Okay, ma'am. So sorry for the disturbance.
No, I'm not sure. It's very
Yes, ma'am,
unstable.
Shanti.
Yeah, I will continue and I'll finish it off.
Okay, ma'am.
IV fluids are important because they need for circulating the blood volume and maintaining the blood pressure. And the recommended fluids are isotonic crystalloid, ringer lactate, and normal saline. Next slide, please. Sorry. Next slide. Okay. The sixth component is that is examine and isolate. Examine for the 4 T's, that is tone, trauma, thrombin, and tissue. You examine the genital tract to rule out this thing. And now this is the pingal. How many people? So many people are required because that is one should stand on the head side and for the vital signs, and another person should stand on the right side of the patient and for the pulse and all, and another patient should sit on the perineum. Next slide, please. Now we have come to the stage of when she is responding to the first line of drug, then it is called a refractory PPH. Now, to prevent that surgical intervention, there are so many measures, non-surgical intervention, that is compressive measures and intrauterine balloon tamponade and anti-shock garment. And we are continuing the uteronics and also second dose of tranexamic. Next slide, Saidi. Aortic compression is the concept of breaking. Audible?
Yes, ma'am, audible.
Okay.
You're audible,
The concept is to maintain the blood flow to the superior portion of the body, preventing the blood flow to the inferior portion. And the operator stands on the right side of the patient, and we should keep the left fist on the left side of the patient umbilicus to compress the aorta, and also that we can feel the femoral pulse on the with the right hand. So the absence of the femoral pulse indicates that is a sufficient aortic compression. And the tamponades, this is the Bagri balloon which we use commonly. And whenever it is not available, you can use a Foley with a condom or Foley with a this glove also you can use. Whatever material is available that used to compress the bleeding site. Next, please. Next slide. This is the novel invention by our people, Indian innovations. That is, we are using a cannula inside the uterine cavity and negative pressure is applied, and the blood and all the tissues are sucked out, and you have to keep the suction cannula for 24 hours. Next slide, please. And this is a non-pneumatic anti-shock garment. This is a low technology, affordable first aid compression device for stabilization of patient with hypovolemic shock. And all the other
We cannot hear you, ma'am. Shanti Rani, ma'am.
Irka. Okay, you put the next slide,
Okay.
please.
And this is the anti-shock government. Everybody is knowing, and it is reusable, and we should try to purchase and other interventions are uterine artery embolization, compression sutures of various techniques, and uterine artery ligation, and bilateral internal iliac artery ligation. And at the last resort, we can go for a hysterectomy, especially in a conditions like PAS. And regarding blood and blood products, timely and adequate transfusion is the most important aspect. And delayed transfusion and inadequate transfusion is going to be not useful for the patient. And also you should give a component therapy, and this thromboelastograph or a rotum can be used nowadays. What component should be replaced? And usually in a massive transfusion protocol, we use PRB, FFP, and this platelet as 1:1:1 ratio. So this is the
1:1.
PPH bundle. Previous slide, please. First, Amstel management, what we are doing. And if it is not responding, call for help and you do a first response where it consists of this intravenous fluid, tranexamic acid, uterotonics, uterine massage, and bilateral uterine compression.
Thank you, ma'am. Thank you, Shanti, ma'am.
There is some disturbance with the Shanti Rani.
Yes, ma'am. Yes,
So
ma'am.
the PPH emotive bundle is really helpful, which reduces the incidence of mortality. Yes, Radhika.
Next
Yes,
two
ma'am.
slides I cannot present this. Then I can make it as a request because I put the last slide as Sampath Madam's slide. It's not coming, unfortunately. So two more things I want to say, that is no woman should die when bringing a life to the world. And second one is that please vote for Sampath Madam. She is the mentor for so many of us, and also she is a very hard worker. You should say simple and humble person, and she's a shining star from South. So please, my request for all, vote for Sampath Madam, the upcoming president. I think this message without interruption.
Thank you, Shanti. There is some net connection problem, I think. No problem. But emotive bundle, you have covered all the things. Then it is important. So the main is all the things should be continued at the same time. Massage, oxytocin, tranexamic acid, what she told us, the drill and the methods before going for the surgical methods, mechanical methods, everything explained. Shanti Rani has explained it with detailed. So if you follow this, I think all maternal mortality will be reduced in many places. Thank you, Shanti, for the wonderful presentation. Okay. Radhika.
Thank you, ma'am. Yes, ma'am. Thank you, Shanti, ma'am. We'll move on to the next topic. There is a panel discussion on hypertensive disorders in pregnancy. I welcome the moderator, Dr. Aditi Rathore. Madam is a obstetrician gynecologist, has completed a OBG diploma in hospital administration, and she's affiliated to Rathore Nursing Home in Johora, and she's a consultant in Rathore Nursing Home, and she has been a faculty international national conference, receiver
She is
of
the
PMSMA award, secretary of Rathore Obs and Gynae Society, executive member of AMPOGS, executive member of Safe Motherhood Committee in FOGC. Welcome, Dr. Aditi, madam. And I am proud to invite Dr. Sumati Surendran, ma'am, who is our professor, Department of OBG, Institute of Social Obstetrics and Government KGH. She is Government Hospital KGH in Chennai, and she has over 30 years of government service and 25 years of experience in the field of obs and gynae. She is a UG and PG teacher for more than 20 years, and she's a master trainer in emergency obstetrics, specially trained in colposcopy and areas of interest are cancer screening and social obstetrics. We welcome you, madam. And the panelists are Dr. Neha Saraf, who is ex-secretary Ratlam Obs and Gynae Society, consultant Ankur Hospital Ratlam, obstetrician and laparoscopic surgeon. Welcome, Dr. Neha, madam. Dr. Roma Sharma Hada, I welcome her, and she is she works at the district hospital in Department of Obs and Gynae, Mansoor, and also she works in Ratlam, and at present she is the gynecologist in Dr. Nazia Sheikh. She is a postgraduate from Visakhapatnam, Andhra Medical College, and she's done her MBBS also from Andhra Medical College. She's done her fellowship in reproductive medicine in Ramachandra Medical Center, Smart Department. And professional experiences, she worked at Mehta Hospital in as a registrar, and she's currently working at Sri Muthukumaran Medical College. Welcome, madam. And I welcome Dr. Teresa Karpagaselvi, who is my colleague, who has done MBBS at Madurai Medical College and MDOG at Madras Medical College. She worked in Tamil Nadu state government for 2 years and worked as senior resident in ESIC hospital, Meenya. And she's specialist of gynae in ESIC hospital, Tirunelveli. Her field of interest is urogynecology. I welcome Dr. Teresa, madam. I welcome Dr. Sonia and Dr. Shefali Shah.
Thank you,
I
ma'am.
welcome, also welcome Dr. Siraj, who's also joining as the panelist. Thank you all the panelists, and let's move on to the discussion now.
Aditi ma'am, kindly share your slides, ma'am.
Yes.
Aditi ma'am.
சிராஜ் இப்பதான் பேனல் ஒண்ணும் இல்ல ஹெச்டிபி தான் சும்மா ஆன் பண்ணுங்க அப்படி கவனிங்க நடுவில் வந்து ஆன்சர் பண்ணிட்டு
Aditi ma'am, are you there?
Yeah, I'm there. Sorry, I had a network issue basically. Am I audible and visible?
Yes, ma'am. Now you are audible.
Yes, I think could you share the screen because I'll not be able to share the screen from my laptop. It is hanging. So I've joined from the mobile. Saiti, can you hear me?
Yes, ma'am.
So
What shall we do?
will you be able to share the panel?
Can you share the slides with me, ma'am, in group?
Acha, you don't have them? Okay. Okay, I'll try to share from my side. Yeah. You don't have the panel here, Saiti? It's okay.
No, ma'am, I'm not having the
Just
CV,
give me a second.
slide deck.
Yes, it's okay.
Aditi.
Aditi, where is the ping?
Am I audible?
Aditi ma'am.
Aditi is not there.
Ma'am, I'm there. Am I audible, ma'am?
Yes, you are audible. You are audible.
My
Where is
video
the
is not working. So I'm just sharing the panel, ma'am.
Okay.
Can you see it?
Yeah, it's just screen share.
Yeah. Yeah, you can see it, no?
Yes, we can
Aditi,
see,
we
ma'am.
can see.
Yes, ma'am, we can see it, ma'am.
made it full
If
screen.
possible, can you make it full
Right.
screen, ma'am?
Good evening all. I'm sorry for this technical glitch. Actually, there's a little problem with the network. So thank you, Sampath Kumari ma'am, for giving me this opportunity to conduct the panel. And this panel has been made by ma'am herself, and I'll just be conducting it. And I will share all the best, knowing her as the person she is during my past, encounters with her. She's a very enthusiastic, energetic, intelligent, and fun-loving person, a complete package. And I wish her all the best. And I welcome her, and I'm proud to introduce her to the Ratlam Society and other societies. So we will just, I might not be able to see all of you at a time because it's the. So first of all, we'll just, in short, we want to know what is HDP. Can you classify HDP? So I would request Dr. Neha. Dr. Neha, are you there?
Aditi slide is not changed, Aditi.
See, ma'am. Can you see, ma'am? I'm changing.
No, ma'am, we cannot
No,
see the
we cannot
slides
see.
changing, ma'am.
You cannot see?
No, ma'am, we can see only the first slide still.
Sure, ma'am, it is changing on my phone, on my thing.
Okay, once reshare it, ma'am. Stop share and reshare it, ma'am.
Okay. So I think I've shared in the group. So
Can send it to Saiti, no?
okay, ma'am, I've sent it. Right. I'll just
Okay, ma'am. So she can share it. Sagiti?
I'm sharing. Can you see the slides again?
No, ma'am, not yet. Yeah, just now.
Yeah.
Now you can see.
Ma'am, is it changing?
No, no, I think we have to slide share.
No?
Yes, now
Yes,
it's
now
Now
changing,
it
ma'am.
is changing, ma'am. Changing, ma'am.
Okay. So I would request Dr. Neha, are you there?
Class, it is seen now.
Yeah. So I asked Dr. Shefali Shah from Ratlam, Shefali, could you please classify hypertension, HDP?
Yes, sure, Dr. Aditi, and thank you for giving me this opportunity. So, as we all know that hypertensive disorders in pregnancy we classify as before 20 weeks and after 20 weeks of gestation. And before 20 weeks, it can be a chronic hypertension or white coat hypertension or mass hypertension. And but after 20 weeks, we have to really take care of gestational hypertension, preeclampsia, and it can be transient gestational hypertension. And preeclampsia amongst these is the most dangerous, as we all know.
Okay,
So
thank you. So
that's
we know it is basically before 20 weeks and after 20 weeks, and now you have to classify according to whatever, if it is with proteinuria, superimposed preeclampsia, chronic hypertension, and eclampsia. So gestational hypertension retention is more than 20 weeks with BP more than 140/90. Now it is like 140/85. Chronic hypertension, known case of hypertension or less than 20 weeks without GTN or multiple pregnancies. And preeclampsia is a multi-system inflammatory disorder beyond 20 weeks of pregnancy. And it is usually hypertension with significant proteinuria. So now there is non-severe preeclampsia, which is without premonitory symptoms. Normal HTP lab parameters are there. Then severe preeclampsia where the blood pressure is more than 160/100, plus minus premonitory symptoms and normal lab parameters. And the premonitory symptoms are headache, blurring of vision, vomiting, right upper quadrant pain, sudden excessive weight gain, and severe edema. Then the abnormal lab parameters are low platelets, elevated liver enzymes, elevated serum creatinine, and abnormal coagulation profile. Then Dr. Roma, could you please tell about the early onset and late onset preeclampsia? Dr.
yes,
Nazia?
ma'am.
Achha, Dr. Roma is there? Yeah.
Am I
Welcome,
audible,
Dr.
ma'am?
Roma.
Good
Yes,
evening
you're
to all the respected members. Ma'am, thank you. Yes, we can classify it early onset of pre-eclampsia on the basis of gestational age. If it is if it is evident before 34 week, then we will label it as early onset. And if after 34 week, then we will label it as late onset pre-eclampsia.
and then
Hello.
so hypertension disorders complicates around 8 to 10% of all pregnancies, and preeclampsia complicates 3 to 9% of pregnancies in developed countries. Dr. Nazia, could you please tell the risk factors just to assist
Yes.
what can you discuss?
Yes, ma'am. Good evening, everyone, and thank you for giving me this opportunity. Justice score is recently devised parameters by Foxy, which includes clinical and all the risk factors, ultrasound findings. So it's a together overall scoring, and in that we have like women born for small for gestation. Hello.
Yes.
Yes, we take certain risk factors. First thing is clinical, ma'am, then age of the patient, and followed by any risk factors like obesity and type 1 diabetes or GDM. Adilama, if previous history of hypertensive disorders in the pregnancy, or the patient is having chronic hypertension, or certain other risk factors like familial history or prematurity, previous history, or IVF ICSI conception. So there is a different type of scoring depending upon the risk factors ranging from 1 to 3. And it should be minimum 8, more than 8 positive to be taken as a positive gestosis score. Hello.
Yes. Thank you. Thank you so much. So now we'll come with our keeping this background. Yes, keeping this in our mind, we'll come to our first case. So I would like to ask Dr. Neha, are you there? Dr.
Ma'am, she
Teresa?
was a PG, ma'am. Neha is a PG who joined.
Teresa is there.
No, Dr. Neha Saraf from Ratlam. Is she there?
Okay.
Okay, so this is a 24 weeks prime. Dr. Nazia? Yeah, so
Yes,
24
ma'am.
weeks primary with blood pressure 150 by 100. And hello?
Yes, ma'am. I'm hearing, ma'am. This is a case
Hello?
of yes, ma'am.
Yeah. So
I can
this is
hear
a
you.
24 weeks primary gravida with a blood pressure more than 150 by 100. He came to a doctor with no other complications. So what is your diagnosis and how will you manage?
Ma'am, this I will recheck the BP first because it can be transient. But here, seeing the BP recording of 150 and diastolic is more than 100, I would label and safely take as gestational hypertension, early onset, and I will start labetalol, ma'am, as early as possible to prevent complications.
So because it is a
And
case
all,
after 20 weeks, so it is a gestational hypertension and the BP is more than 140/90 and there are no other complications, so label it as gestational hypertension and you start labetalol. Right, fine. So how will
yes, ma'am.
you, what are the various medications and what are the doses? How will you start?
So the first thing is labetalol is the first drug of choice, which is alpha. This is alpha plus beta blocker, especially more of alpha action. So we can give a maximum dose of 1200 in a day, and it can be given BD or 3 times a day doses. Then the other drug is nifedipine, which is a calcium channel blocker, ma'am. That also like maximum 30 mg we will give. It's a slow release preparation. And the methyl dopa it acts on central nervous system, sympathomimetic drug. And then there is a IV drug card. There are certain IV drugs like hydralazine, which is used if the BP is not controlled with the above drugs. Usually with labetalol itself, BP gets controlled, ma'am, maximum of 1200 mg. If not, then we have to add other drugs like labetalol, nifedipine. And if not controlled, then IV hydralazine will go, ma'am.
So basically now the Gestosis Society says that we should not like give the maximum dose. We should go to add the other drugs soon enough and not take the dose to the maximum dose. And ideally, because methyl dopa is not available, we start with labetalol and then usually we add nifedipine. Right. No, thank you. So Now we come to another case. Dr. Siraj Fatima, are you there?
I think Dr. Siraj Fatima not joined, ma'am. Dr. Siraj is not joined yet. Dr. Teresa is there.
Dr. Teresa, she's there. So Dr. Teresa, a Gravida 2 Para 1 Live 1 with the gestational age of 32 weeks on antihypertensive since 4 weeks, complaints of headache and blurring of vision. So on examination, our per abdomen examination corresponds to gestational age and a BP is 170/100. So what is your diagnosis and how will we manage this case?
Is the case of preeclampsia with imminent signs and symptoms of eclampsia, like headache and blurring of vision. We have to admit the patient and we have to administer max alpha.
Yeah. So because
Loading
you
dose and
don't give
also the
there's a
maintenance
case
dose will need to be given for 24 hours, and also the BP drugs, labetalol, nifedipine has to be given. The loading dose is 4 gram. IV,
yes.
I mean 8 ml diluted with NS. It has to be I mean 20 ml, and then straight IV has to be given, and also the IM dose need to be given, and it has to be continued up to 24 hours. The period of gestation is 32 weeks, so we need to administer the steroids also, and the PIH investigations need to be sent. Urine output need to be monitored, and also the knee jerk and the respiratory rate to be monitored.
So as you rightly said, she's 32 weeks, so we have to, and she's having imminent symptoms. So basically, this is a case of preeclampsia, and we have to give her stabilize the BP, give her magnesium sulfate, and plan for termination. And obviously, we have to give her steroid prophylaxis. So which regime do you usually use, Dr. Shefali? Are you using the Prichard regime or you dispass?
No, here in Vietnam, I'm usually using that Precharge regime in which we give 4 gram of IV magnesium sulfate diluted with like it's an 8 ml diluted in 12 ml of distilled water, and we can give it IV. Either by an infusion pump will be better, and then we'll give. Maintenance dose and 10 grams IV, 10 grams IM we'll give, and afterwards we'll give 5 grams every 4 hourly until 24 hours or until the seizures subside, or whatever lasts 24 hours we'll have the gap, or until the last delivery.
Whatever is later.
Whatever is later, yes.
So, and how do you monitor for the toxicity of the drug?
So we will do the urine output monitoring, respiratory rate monitoring, and the knee-jerk reflexes. And the antidote will be calcium gluconate, as we all know that. And urine output should be 30 ml per hour. Yes, and we will always see the premonitory symptoms.
So we will see
headache, blurring of vision, upper abdominal pain, urinary output, and obviously fetal movements also we'll see. So,
Aditi ma'am,
can you see the screen? Can you see the screen?
yes,
yes, ma'am.
yes.
So the next slide. Saiti.
Gayatri, something is. I cannot see the screen myself.
But we can see the screen.
You can see the screen?
Yes, headache, blurring of vision.
Yes, ma'am.
It's not moving.
Yeah, it's not moving.
I think you
I
can
think
start
you can
sharing
start
again.
sharing again.
Yeah. Can you see the screen? I'm sharing again.
No, ma'am.
We can't see the
We
slides.
can't see the slide.
Yeah, just- Actually, there's a lot of internet instability on my side
Internet issues.
today.
Yes, ma'am. We can
So
understand. We can
sorry.
understand. No problem. No problem.
Internet
Is it
problem
visible
with
now?
Aditi? No,
No, ma'am.
Aditi.
Not yet.
No,
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 ma'am. Not
Is
yet.
it visible now?
no.
No, ma'am. No, ma'am.
Aditi,
Is
you
it
can ask
visible now?
Aditi to press.
Saiti, could
No, ma'am.
you showing that I'm screen sharing?
Aditi?
No?
Yes, yes. Now it's visible.
Is it?
Yes.
Yeah.
No, it's not visible for us.
Is it
Yes, it is
visible?
visible. Yes, proteinuria, visible.
Yeah?
Yes, Aditi, continue.
Yeah. Yes, ma'am. So, these are the imminent signs: headache, blurring of vision, upper abdominal pain, and decreased urinary output, and we have to watch for the fetal movement. We have to monitor the patient. So, you have to. How do you test for proteinuria, Dr. Neha? Seen Dr. Neha has joined.
Good evening, ma'am.
Welcome, Neha.
Thank you, ma'am. Thank you so much.
Dr. Neha is a past secretary at Ratlam Society. Welcome, Dr. Neha.
Thank you so much, ma'am.
You have to answer, Neha. How will you do the proteinuria?
Actually, my network connection is very unstable, so I was just leaving and automatically joining and leaving. So I am not like oriented to the question.
Okay.
Can you please repeat the question, Aditi
We
ma'am?
can hear you now. You can. Yeah. So how do you do proteinuria testing basically?
Ma'am, I send it to lab for urine albumin testing. And I guess a 24-hour urine protein is the best. Am I audible now?
Yes, you're audible now. Hello.
Hello. Madam?
Dr. Neha, you're not audible right now. Dr. Shafali?
No, you're fine. PH3.
Yes. I can read. Am I audible? So, what question?
Yes.
What is the question, Dr. Aditi?
Ma'am, actually, ma'am, there's no electricity this side. So, the network is very unstable. Ma'am, can you see the screen? Could you continue? Yeah. Yes.
Yes, ma'am.
Yes, ma'am. Yes.
Radhika? Radhika?
Yes, ma'am.
The Aditi's network is not continuing, so I will continue. Okay.
Yes, ma'am.
The next slide, PAH tray, as all of us know, it should contain the gloves, magnesium sulfate, 16 ampules, and 10 ml syringe 3, calcium gluconate, lignocaine 2%, knee hammer, 20 ml syringe, IV fluids, IV set, and labetalol, nifedipine, and 2 ml syringe. This is the PIH tray should be kept all over casualty, antenatal ward, labor ward, and in theatre. This is the thing should be kept. You could not go and search for the magnesium sulfate once the patient has come to the hospital. Next slide. Next slide. Sahiti. Now this is the next patient, 28 weeks, gravida 2 P1L0. Patient was on antihypertensive and now she had twice fits in the house. And when she came to the OP, she has thrown the fits third time. So it is clearly known that it is a case of eclampsia. So we'll start with whoever is there. Teresa is there, I think. Teresa, how will you going to manage this patient? The patient comes with a
circulation
ESI.
we need to see, and then we have to stabilize the patient. Max self need to be given. And then BP need to be stabilized, and then we have to terminate the pregnancy.
Okay, Teresa. So the first thing is
investigations need to be done.
Admit the patient, lateral legubitus position, remove the sections, give oxygen. So how will you give the IV labetalol? Any one of you, Nega? Now Teresa is Nega or Sonia. Sonia is there.
Good evening,
Sonia.
ma'am. Good evening.
Yes,
Thank
Sonia.
you for
Can
the
you tell how will you?
So injection hydralazine can be given either 5 mg IV or 10 mg IM can be given. It has to be
Sonia,
repeated.
hydralazine is available in our place.
Routinely, we are giving first line of drug is labetalol, ma'am. We go with labetalol.
Yes,
We start
hydralazine
with
is not
20
available.
mg. Routinely, we don't. We start with labetalol IV 20 mg as a bolus to start with, and further we can increase till the BP is still not controlled. We'll check after 10 minutes, and then if still the BP is high, we'll go with 40 mg of labetalol. Later, if needed, then we have to proceed with 80 mg, ma'am. Every 10 minutes, if needed, for up to two doses, and then the maximum dose should be 220 micrograms, ma'am. Can switch to other drugs if it is there's inadequate response with labetalol. But first line drug is injection labetalol, ma'am. IV, slow
Yes,
IV.
Sonia. Always with IV labetalol, the
It usually
BP will get controlled. Once it is stabilized, if the patient is stable, continue with oral labetalol. And if the patient is not stable, put the rail tube, and through the rail tube, give the labetalol and the calcium gluconate. The other drugs are not, most of the time in some hospital, they are using IV nifedipine, but in our places, commonly we use only the
Oral.
IV labetalol. Some with the anesthetist help, nitroglycerin patch is also used in some places. Okay, next slide. So eclampsia patient, admit the patient, remove the, always get the end one, lower and one other people. Call for help, remove the secretions, give oxygen, start IV line, take the sample for investigations. One should start the labetalol, one should start the magnesium sulfate. The another person should put the catheterize and see the pervaginal examination and to see whether if the patient is in labor, if suppose 6 centimeter dilator, deliver it vaginally. And if she is not good and the Bishop score is less than 3 means go for emergency LSCS. In these emergency cases, always better to go for LSCS. 32 weeks primary and labetalol and nifedipine comes to OP with abdominal pain. The abdomen is tense and tender. So any one of you who is there?
Yes, ma'am.
This
I'm
is
Dr.
Nadia,
Shefali.
ma'am.
I'm there. And as the patient is 32 weeks on
Yes.
labetalol and nifedipine, and she's
Yes.
having severe abdominal pain, and the abdomen is also tender, so the diagnosis is she is having APH, and we will obviously admit the patient and have the preliminary investigations like coagulation profile, platelet count, and liver function and renal function tests, and we'll immediately proceed for LSCS and do the everything should be managed like as such.
Yes, as usual. So even if it is a stillbirth, go for LSCS. That is the best answer. So the other complications are abruption, visual disturbances, intracranial bleeding, pulmonary edema, oliguria, that is acute renal failure, glomeruloepitheliosis. And for the baby, it is growth restriction, preterm, HAE, low birth weight, and perinatal death. So in this pregnancy, if the patient is having eclampsia, means there is the recurrence of pre-eclampsia and eclampsia in the next pregnancy up to 30%. Next slide.
Press
Sakshi,
also,
next
madam.
slide.
Complications.
What? Yes, sir, that will be coming later. Yes, press is also one of the complications, Teresa. Yes, sir. 34 weeks primary, patient is an on antihypertensive, comes with upper abdominal pain. Always when the patient on antihypertensive complains of upper abdominal pain, don't tell that take antacid and Gaviscon, you will become normal. Think of hemolysis, elevated liver enzymes, and low platelets. So the patient is on labetalol, 100 milligram BD. So how will you proceed? Nausea?
Yes, ma'am. When she's complaining persistent abdominal pain, there might be liver damage or peripheral liver. So elevated liver enzymes is most common. So we have to keep HELP syndrome in mind, and we have to do other investigations, send blood for CBC and check for the platelets also. Other than that, BP recordings also to be stabilized. And then also check for placental sufficiency, like do a Doppler, look for the AFI, and also see the baby's well-being. And for HELP syndrome, we can deliver the baby, we can deliver the patient once she is stabilized, ma'am. Like BP is normal, enzymes are within limits. After giving betamethasone and magnesium sulfate therapy, we can safely deliver the patient. If she is away from the
Nasia,
term, like
now the patient is having that platelets of 30,000 and the liver enzymes is elevated. Can you wait for steroid effect?
no, ma'am. We have to
No.
transfuse the platelets in such a scenario, and then we have to deliver the patient.
So whatever may be the conditions, whether 28 weeks or 32 weeks or 24 weeks, in the complicated cases such as severe preeclampsia, HELP syndrome, eclampsia, if the patient is not in labor, you have to deliver by emergency LSCS.
Emergency LSCS.
Yes, steroid effect and magnesium sulfate effect can be have only in case of gestational hypertension. As previously Aditi told, the hypertensive disorder is gestational hypertension, that is BP elevated after 20 weeks with 2 readings without proteinuria. And if it is associated with proteinuria, it is a preeclampsia. It can be a severe or non-severe with end organ damage or without end organ damage. Third is the eclampsia. The fourth category is the non-hypertensive patient going for pregnancy is chronic hypertension. This chronic hypertension can be also superimposed with preeclampsia and eclampsia. So the delivery, suppose the preeclampsia is present in 24 to 28 weeks, means we know very well it is difficult to revive the baby. We go for the terminations. And if the preeclampsia is identified after 37 weeks also, immediately we can terminate. The in-between period of 28 to 32 weeks only, always in dilemma. Even if it is in dilemma, if you don't have the high NICU center, stabilize the patient and refer the patient to the place where the NICU center is available. Or counsel the patient that it is difficult to revive the baby. So always don't delay. The maternal mortality has to be reduced and the mother complication has to be reduced. Always, as far as the HDP is concerned, we are bothered about the mother and not about the baby. Next slide. Next slide, Sahiti.
Sahiti
is having 2 programs, I think. Anyway, the next slide is for Teresa. Teresa, this is the patient, primipara, delivered 2 weeks back on antihypertensive. Since at request, the patient was discharged on 3rd day itself. We do not know if we discharge the patient on 3rd day, she will continue the hypertensive tablets or not. And she came back on 6th day with a headache and BP of 160/100. How will you manage, Teresa?
We have to admit the patient and admit the patient, control the BP, and also MRI need to be taken.
The MRI picture is shown. So previously you told no the complications, the same complication here. The posterior reversible encephalopathy syndrome. So as Teresa told, you are going to give the antihypertension tablets, labetalol. And if the patient didn't receive the magnesium sulfate earlier, that is before delivery, within 1 week or 2 weeks, we have to give the magnesium sulfate and stabilize the patient and counsel the patient that these symptoms will become normal after 4 weeks. It is always reversible. So this is the latest, last complication which can happen with the PAH. Next slide. I think all the cases has been over. The prediction, any one of you, Nasia, can you tell anything can predict preeclampsia?
Yes, ma'am.
Next slide, Sagiti. Sagiti is not there. You tell what are all the predictions, Nasia, which test can be done.
Yes, ma'am. Screening test, ma'am. In first trimester, we have placenta-like growth factor and also soluble fibrinogen like tyrosine kinase, SFLTS, ma'am. Along with that, there is a first trimester during the NT scan, we see uterine artery Doppler, ma'am. If there is a high resistance, it's also a predictor. Hello.
So this, yes, correct. As you told previously, we used to go with the left lateral, previous slide, left lateral test, the BP and all. Now the predictor is SFLT by PAGF. The placental growth factor. Yes, placental growth factor alone is not helpful. So SFLT by PAGF ratio is always helpful. When it is, this has to be done from 12 weeks. It is very, very costly. So SFLT by PIGF, if it is 30, means we have to repeat the test every 4 weeks. And if it is between 30 to 80, means it has to be repeated every week. If it is more than 80, means you have to terminate immediately. Now the only predictor which is useful is SFLT by PIGF. That can not able to done in the government hospital, but in the corporate hospitals, it can be done. These are all some studies, prognosis studies, PIAS model, which is like our gestosis score with some investigations. The Pelican study is with the PIGF, growth factor alone, whether it is more than 100 or less than 100. With this study, we can prolong maximum for 1 week. But if the patient is in a severe condition, we cannot prolong even for 1 week. Next slide. Next slide, Sagiti. So the as far as hypertensive
Can you see
disorder
the
in pregnancy is
slide?
concerned, the BP monitoring is very, very important. We have to exclude the other diseases. Monitor the BP, appropriate cuff, appropriate position. If the patient is not coming, you will be having the phone number of the high-risk cases. Follow up the patient, call the patient and see every 4 weeks. And after 28 weeks, call her every 15 weeks and tell her the 3 symptoms, the 5 symptoms, headache, blurring of vision, upper epigastric pain, reduced urinary output, reduced fetal movement. If anything is present, it can be the preeclampsia and it has to be terminated immediately. So control the hypertension and prevent the complications. You cannot prevent PAH, but you can prevent the complications. If you don't have the facility, stabilize the patient and refer the patient to the place where the facilities are present. And no mother should die because of hypertension, because if you identify and treat, you can prevent the complications and reduce the mortality. Thank you. The next slide is, finally, I am contesting. Last slide, Sakiti. Why are you going back? So this is, I am Professor Sampath Kumari from Chennai, contesting for FOXI President. All of you, please vote for me. 34 years of experience, and now we are attached to the medical college, and I was FOXI Adolescent Committee Chairperson and Vice President. Please support. Voting time is August 1 to 10. Till 16th, you can verify whether you belong to A category or B category. B category means you have to upload the certificate, send the mail to the FOXI office, and change to A category. Thank you.
Sure, ma'am.
Radhika, official
Yes,
vote of
ma'am.
thanks.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am, for the
Thank you,
opportunity.
ma'am.
And
Yes.
I thank all the.
Hey, we didn't have Sumati. 1 minute. Sumati Surendran is there. Entirely. Suddenly I joined. I forgot. Dr. Sumati?
Sumati ma'am has not joined.
She's not there. Okay. So we have made her as an expert now. So I thought she can give the final conclusion. Okay. Thanks to all the panelists. Instant moderator, Teresa, Nekha, and Sonia able to identify it. Who are all the other 2 panelists, Radhika? Shaili.
I'm Shifali. I am Dr. Shifali
Teresa
from
and Siraj.
Ratlam.
Shifali. Yes,
Yes,
Shifali.
ma'am.
All of you.
Shifali.
Had a
Thank
good
you.
discussion. Thank
Thank
you.
you,
Thank
ma'am.
you.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you. Thank you. Roma was there, but I think Roma didn't join.
Yes.
Anyway,
Yes.
we'll go with the vote of thanks. Dr. Radhika?
Yes, ma'am.
Teresa and Radhika are twin sisters.
Thank you, ma'am. Thank you, ma'am. 1 minute, ma'am. 1 minute. I will. 1 minute. 1 minute. I thank the organizers, Dr. Sampath ma'am, and Dr. Amala ma'am, Dr. Ramani Devi ma'am, who took the time to organize this webinar. I thank the president of Opsam Gynae Society and Dr. Aditi Rathore, secretary, and Dr. Sharwari Jadhav, president of Meeraj Opsam Gynae Society, and Dr. Nagavarkar who is the president of Kolhapur Society, and Ranjit Kilater, who is secretary of Kolhapur
Radhika,
Society.
video cut பண்ணிடு. Yes. இப்ப விடுது சொல்லு.
I thank Dr. Shanti Rani ma'am, who took her time to present the emotive bundle in a very nice manner. Except for the internet issues, it was very interesting. I thank all the panel discussion members and the moderator, Dr. Aditi Thor ma'am, who shared all the cases, very important cases. And I thank Dr. Nazia Sheikh from Muthukumaran Medical College and Dr. Teresa from ESIC, Dr. Shafali Shah and Dr. Neha Saraf and Dr. Roma Sharma, who gave their contribution. I thank Sahiti for a wonderful coordination. And thank you, Sampath ma'am, for guiding us. And let's all vote for Sampath ma'am, who's done a great job in and also encouraging all of us to come to all these webinars and we all developed our knowledge as well as participated and even social interaction and all that. So we have to definitely vote for Sampath ma'am. I request everyone to support Sampath ma'am and make her the Foxy president in July August elections.
Thank you, Radhika,
Thank you
Teresa.
so much. Thank you, Sampath ma'am.
Good evening. Good evening. Yes, we can live. Have a good.
Thank